So welcome, everybody. I'm happy to share with you our frequently asked questions presentation in an attempt to share with you the lay of the land around all the different testing, endocrine testing modalities that we offer here at Doctors Data. So let's start at the very beginning. Why should you test both hormones and neurotransmitters together? Well, the scientific answer is because hormones can impact synthesis, breakdown, receptors, and action of neurotransmitters, and vice versa. Neurotransmitters can impact synthesis, breakdown, receptors, and action of hormones. But the clinical reason is that there are a number of symptoms that could be caused by either and both neurotransmitter and hormone imbalance. So it can be hard to tell by symptom alone which systems are involved, and if we guess, we often get it wrong. Testing both casts a wider net, which enables you to narrow down your treatment. Ideally, you would consider testing together as a baseline to address the entire neuroendocrine system. This image shows some potential interactions between hormones and neurotransmitters. So as an example, you see here on the right hormones and how it plays a role in how estrogen plays a role in hypothalamic temperature regulation, and it can increase serotonin production and receptor activity. Serotonin promotes cortisol, and it stimulates ACTH, and it can play a role also in temperature regulation. So with any symptom that a patient presents with, you might question, is this hormone-related or neurotransmitter-related symptom? Often, the answer is often both because of the symbiosis between the two systems. So where should you begin with testing? If you need to prioritize, or if your patient is on a budget, you can base the decision on the most bothersome symptoms and the most likely causes, as well as taking into account the patient's age and stage of life. So I like to say that I always include cortisol because of the role the HPA axis is going to play in the neuroendocrine system in general. Stress, anxiety, depression, it's all related. So cortisol is always one of the very first things to test. In children, because they don't have a hormonal cycle yet, usually it's just neurotransmitters and cortisol. Anytime there's any mental health symptoms taking place that are not related to hormones or a cycle, we're just thinking neurotransmitters and cortisol. However, as soon as hormones are involved, such as things like a low libido in a man or a woman, a postmenopausal woman with hot flashes and insomnia, or somebody with PMS, PMDD, irregular cycles, menorrhagia, or even oligomenorrhea, we're thinking hormones first, as well as cortisol. Which testing medium should you choose to evaluate hormones? Well, there are three main ways to test hormones. There's serum, there's saliva, and there's urine. And there's a whole host of reasons why you would choose one over the other. So this is just a little flow chart that can be a handy place to start to help you figure out which medium to use. So start here at the yellow star. If your patient has hormonal symptoms and they absolutely need insurance coverage, then serum is really going to be the only choice for them. If they're already on topical bioidentical hormone replacement therapy, then saliva is really going to be the only choice for them. And then if they have a personal family history of estrogen-dependent cancer, breast, ovarian, or endometrial, or if they're over 45, then you're thinking the comprehensive plus, because that's going to look at the metabolites, estrone and estriol. And if not, then it's fine just to test the comprehensive hormone profile where you're just looking at estradiol. In all cases, if there's any concern about cancer risk, organ health, metabolism, enzyme function, or detoxification pathways, or if there's been inadequate symptom relief once treatment has been initiated, that's when you're going to be looking at urine or our HuMap. So when to retest? With urinary hormones and metabolites, we recommend retesting about 12 weeks after starting treatment. For HPA axis testing, it's going to be a little bit later because cortisol levels shift slowly after beginning treatment, even when the symptoms are improving. So we recommend waiting 6 months to a year just to prevent frustration in your patient if they start to feel better and you retest them too soon and those levels haven't changed yet. When there's hydrocortisone supplementation, you can test 8 to 12 weeks later with the caveat that the patient must discontinue their hydrocortisone for 4 to 5 days in advance of collection in order to rule out interference from the hydrocortisone with test results. So in order to get endogenous levels, they need to be off hydrocortisone for 4 to 5 days. For salivary sex hormones, you're going to retest about 3 months after starting BHRT and or after each dosage adjustment. And when dosing is stable with your patient, you really only need to retest yearly, always sooner if there's a change in the symptom picture or if there's a dosage adjustment. For neurotransmitters, you're going to wait about 6 months after initial testing as they too take a while to shift, sooner if it's indicated, or when there's a change in symptoms or psychotropic medication is added or adjusted. So can you get help with report interpretations and treatment considerations? Yes, you can. You can call and speak to one of our fabulous staff doctors between 8 and 4 Pacific time, Monday through Friday. There's no appointment necessary. You can just give us a call, and depending on how busy we are that day, we could go over 1 or 2 reports. Alternately, you could email us questions, simple questions that are easy to answer, or you can set up an appointment with us via our staff docs at doctorsdata.com email address, and that's going to go to the entire team, so that way everybody sees it, so there'll be no delay in someone getting back to you. Just let us know your phone number and your time zone, and give us a couple options as to best days and times to reach you. So now I'm going to address some questions about our newest test offering, the HuMap, which tests hormones and metabolites in urine. The clinical utility of urine metabolite testing is being able to see how the hormones are being metabolized and moved out of the body. It gives you a view into phase 1 and phase 2 estrogen detoxification as well. There's ratios that can indicate enzyme activity, and there's certain patterns of imbalance that are associated with higher risk of hormone-driven cancers. Which patients would benefit from HuMap testing? Well, pretty much everybody except, children, cycling females, postmenopausal females, males age 12 and over, and anyone dealing with any of these concerns, which are very common in our practices: metabolic syndrome, thyroid pathologies, inflammation, fatigue, insomnia, cognitive concerns, mood, weight gain, BHRT use, personal or family history of hormone-driven cancers, menopausal symptoms, anything related to hormones, erectile dysfunction or BPH in men, PCOS, etc. It's a long list, so take a look at that. But pretty much everybody could benefit from it except children, unless you want to, pretty much except children. And so what are the differences between urine and saliva hormone testing? Well, there's a lot. Mainly that saliva hormone testing measures biologically active free levels that are available to the tissues. It's the best choice for monitoring hormone supplementation because saliva can reflect hormone dosing delivered by any route. So sublingual, vaginal, oral, topical, etc. You can measure it all in saliva. Urine is going to be looking at, again, how hormones are being metabolized, detoxified, and eliminated as they're on their way out of the body. Metabolite ratios can indicate how enzymes are performing, and it can also give you an indication of which metabolites are biologically active. So we don't recommend using urine as a starting point for BHRT supplementation because urine metabolites don't represent tissue levels of active hormones. If you see a pattern of low hormones on a urine test, we recommend reflexing to saliva to confirm that those levels are low before you consider BHRT or before you start your patient on BHRT. We also don't recommend using urine testing to adjust BHRT dosing because of the physiology of hormone absorption, transport, and metabolism. Transdermal application is going to deliver BHRT directly to the capillary beds underneath the skin, where they're going to travel via the red blood cells directly to tissues, where it can be measured in saliva. blood or urine, it's only going to increase if the transdermal dosages exceed the carrying capacity of the RBCs, or if there's kind of a spillover effect. And that's going to mean that the patient is receiving too high of doses. So an orally delivered BHRT will go through hepatic first pass metabolism, which tends to appear higher in testing. So that's why we recommend a 72-hour waiting period after someone finishes their oral use before they start to collect urine, just to try to avoid those very high levels because of first pass metabolism. Will using the HuMap help with dietary and supplement suggestions? Yes, it's a great starting point for determining nutrient, herbal, and lifestyle recommendations to support enzymes and the detoxification of estrogens. It can be a good tool to track metabolism patterns with supplemented hormones. And it can also reveal patterns that are associated with health conditions that impact metabolism, such as hypo or hypothyroid, hypo or hyperthyroid, insulin resistance, and inflammation. In the next 2 slides, I'm going to show you how the treatment guide will give you suggestions for dietary and nutritional support. We're going to focus on the estrogen neighborhood on the right here. Well, actually both. We're looking at androgens and the estrogen neighborhood here. This is in a 68-year-old male on testosterone. And you can see that he is aromatizing testosterone via CYP19A1 to estradiol and to estrone. And I want to draw your attention to the circles on the right, specifically how they relate to the treatment guide. So while the entire estrogen neighborhood is hot, or running a little bit high, we're going to talk about that a little bit later, I'm bringing your attention to phase 2 detoxification via methylation. We're looking specifically to the 2-OH and 4-OH pathways where methylation takes place. And so you can see I've circled COMT as the enzyme that's going to methylate the 2-OH and 4-OH metabolites into the methylated or methyl metabolites. So this is our handy dandy treatment guide that you can find on the website. It is full of all kinds of great information related to supplementation and food. On the right here, you see I was trying to highlight here upregulating COMT because of what we saw in that previous slide for methylation. And I wanted to point out all the foods that can play a role in helping to support the COMT enzyme for methylation. Cruciferous vegetables, soy foods, resveratrol, citrus foods, rooibos and dandelion tea, the spices rosemary and curcumin, and then of course supporting methylation with nutrient cofactors and methyl donors, as well as being aware of the antioxidants that can be formed when methylation isn't occurring. So being aware of supporting that as well. And at the top, I included another piece from the treatment guide, our therapeutic consideration guide, just to show you that if you were to need to downregulate CYP1A1, which really doesn't need to happen in this pathway because we're happy with the abundance of the 2-OH pathway in this particular case. But I just wanted to point out to you how this wonderful list of foods, grapefruit, berries, green tea, broccoli, St. John's wort, how these lycopene from tomatoes, carrots, and watermelon, how this can really influence your treatment for your patient. So what's unique about the HuMap versus other urine tests from other labs? Well, the HuMap is done from a liquid urine collection, so there's no need for reconstitution, which enables creatinine to be measured directly. Page 1 gives you an overview of the most clinically relevant information. And so what you're looking at here is this arc on the left that's pointing out some key findings. You're looking at methylation here in the estradiol pathway, and here you're seeing the ratio of the 3 estrogen metabolites, 2-OH, 4-OH, and 16-OH. Here you're seeing an overlay of cortisol and cortisone, and down here you're looking at some of your patient's enzyme preferences. You'll see that we're going to look at some. You're going to see here on this slide that this is your patient's individualized pathway diagram. We call it a heat map because it reflects your patient's individualized results. You can see where the hormones and the metabolites came from, where they're going and which enzymes are involved, which might need support. And the color coding is simple. Red is hot or higher or abundant. Blue is cold or lower. And red, just to point out, red does not mean high always or bad, because it can be good to have certain abundant hormones in the urine. So it's not necessarily a negative thing if some of these are coming up red. And then, of course, blue is lower. And these are going to change according to your patient's results. So when your patient retests, we would expect this to look much different. So now we'll talk about common questions regarding a urine collection for the HuMap. So does your patient have to stop taking hormones prior to collection for HuMap? Probably, but it depends on the route of delivery because there's a different dosage interval for each mode of delivery. You may have to wait a certain amount of time after your last dose before starting to collect the urine samples, and then wait until the last sample is collected before resuming one's daily hormone dosing schedule. Note that because of the different ways that the hormones enter the body and are metabolized depending on that route of delivery, the dosage intervals for urine testing and saliva testing are very different. So here we're just talking about the dosage intervals for urine. So if someone's using a topical, intramuscular, subcutaneous, or transdermal patch delivery method, they're just going to continue with their regular schedule because that's not going to negatively impact results. If one is on a vaginal, topical, or suppository, we ask they discontinue for 72 hours to try to prevent contamination of the urine. For sublingual and oral, to discontinue 72 hours prior and during sample collection because of what we talked about with that first pass metabolism, how that can elevate levels. And cortisol and hydrocortisone always are going to discontinue for 4 to 5 days prior to sample collection for both urine and saliva. For a night shift worker, the collection times are going to correspond to their pattern of eating and sleeping on a typical workday. So, and the same is also going to go for saliva collection. So the dinner time collection is done 4 to 7 hours before they go to sleep, whenever that is, or before they eat their last meal before bed. The bedtime sample is collected before their longest stretch of sleep for the day, not when they're napping, but when they're having most of their sleep. The waking collection is done after they wake from that longest stretch of sleep, even if it's in the middle of the night. And the post-waking is going to take place 2 to 3 hours after that waking collection. If the patient has to void 1 to 2 hours prior to collection time, they can collect the sample early, but it really is best to collect from as full a bladder as possible. We recommend at least 2 hours since the prior urination before collection, if possible. If a patient can't collect at the requested time, meaning that they're not able to collect a sample, they should hydrate and collect as soon as they're able. Urine samples need to be frozen 4 to 6 hours before shipping. So this means that if one collects their last urine sample at 10 a.m. and they put it in the freezer, they could call FedEx for pickup between 2 and 4 p.m. that day. But it's also fine to freeze it overnight. Okay, speaking of urine, in this next section, I'm going to talk about the most common neurotransmitter questions. So this is the most common neurotransmitter question that we get. Does this testing measure brain levels of neurotransmitters? Well, it's a common misunderstanding that neurotransmitters are secreted and received only in the brain. So let's just take a pause to take a quick review here. Neurotransmitters are the autonomic nervous system's chemical messengers that transmit messages between neurons or from neurons to muscles. They're secreted in the central and the peripheral nervous systems, and the enzymes are the same in the brain and the periphery. We can't measure within the synapse, but urine testing reflects whole body production, and it correlates very well with symptoms. For example, we know that serotonin influences mood, yet 80 to 90% of serotonin is secreted in the GI tract. We also know that increased levels can lead to an overactive GI system, whereas low levels are going to do the opposite. Epinephrine and norepinephrine are secreted in the periphery as part of the stress response to impact muscles and cardiac function. Dopamine receptors have been located in coronary and renal as well as cerebral tissues, and glutamate receptors have been identified in the heart, kidney, lungs, and endocrine glands. So you can see that neurotransmitters are a whole body situation. The neurobasic includes the purple neurotransmitters that you see here outside of these green boxes. So this is the neurobasic test that's going to look at serotonin, dopamine, norepinephrine, epinephrine, glutamate, GABA, histamine, and glycine. The comprehensive profile, neurotransmitter profile, includes all of those things, as well as what's circled in green, which are metabolites and also the amino acids, tyrosine and taurine. So this allows you to see how the neurotransmitters are being metabolized, enabling you to make inferences about enzyme function, such as MAO and COMT. Both tests are going to help you evaluate for deficiencies or excess levels of neurotransmitters, and they can help you figure out which nutrient cofactors are needed in your patients, which is a great way to open the door to working on nutrition. So a couple other examples here. If you ran the neurobasic and you found normal norepinephrine and low epinephrine, and because norepinephrine is going to convert here into epinephrine, you might try to improve levels by supporting the enzyme that's going to convert norepi to epi, and that would involve SAMe and HPA axis support. But if you took it a step further with the comprehensive profile, you could see if the cause of that low epinephrine is excess COMT activity resulting in elevated metanephrine levels. How long should your patient supplement before retesting? Like cortisol, we recommend waiting at least 6 months before retesting because neurotransmitter levels are also going to adjust fairly slowly to treatment. Patients are often going to feel better before they see results, changes in their results, and keep in mind that long-term support is often needed for symptom management. Can you see patients who are using, can you test patients who are using psychotropic drugs? Yes. The results are going to reflect the influence of that medication on the neurotransmitter levels, which can be very hard to predict without testing. Most of the time, patients aren't testing prior to starting SSRIs or SNRIs, so we don't know how their levels are changing. We often will see low serotonin levels and sometimes low norepinephrine levels in patients who are taking these medications long-term. And research supports the depletion with long-term use. So it's just always a good idea to test, even when someone is using psychotropic medications. But for patients who are discontinuing medications, how long after stopping will we see baseline endogenous levels return? Well, it really depends on the drug in question and the half-life of the drug. It takes about 5 half-lives for 95% of the medication to be eliminated. So on average, that's 6 to 8 weeks. The half-lives of some of the most common medications vary from 4 hours to 6 days. I want to emphasize here that we are not in any way advising that one discontinue their psychotropic medications for the purpose of testing, because we know that stopping suddenly can cause withdrawal symptoms, and it can also cause their initial symptoms to return. It's solely for patients in the process who are already in the process of discontinuing their medication. Can patients take amino acids while they're using psychotropic drugs? Yes, but I wouldn't supplement amino acids on top of psych meds unless I first check their neurotransmitter levels. This can help to avoid elevation, especially if a patient is on an SSRI and it's helping their depression, but it's not quite enough. Testing reveals low or low-range serotonin, then you can feel comfortable adding in some 5-HTP without concern for raising their levels too high. What drugs can have a negative impact on neurotransmitter levels? Well, it's important to understand that many medications are going to deplete the cofactors that are required for neurotransmission. Here are some commonly used medications and the nutrients that they have been shown to deplete. So H2 blockers and proton pump inhibitors and antacids are all going to deplete folate, B12, C, calcium, iron, and magnesium. Antibiotics, metformin, and anti-inflammatories have been shown to deplete folate, and oral birth control pills have been shown to deplete folate, magnesium, B6, B12, vitamin C, zinc, and selenium. So it's really important to ensure that you're repleting these nutrients in your patients who are on these medications. This is a chart of some common medications that can increase or decrease neurotransmitter levels or affect their receptors. It's quite the research. It was created by my colleague, Dr. Heidzik. Just because a medication is supposed to increase a neurotransmitter doesn't mean that it necessarily will, but it may be higher than it was prior to starting the drug. So again, another reason to test before starting psychotropic meds if possible. And you can take a closer look at this chart on your own time as it's quite detailed. And lots of good information here. How about cannabis use? Will it affect results? THC and CBD are the two main phytocannabinoids in cannabis. THC has been shown to acutely elevate dopamine, but long-term use has been shown to lower levels of dopamine and glutamate. CBD has been shown to increase serotonin and it activates glycine receptors. So be aware of this with your patients who are using cannabis products. Is creatinine diagnostic? The answer to that is no. Creatinine here is only for the purpose of being an indicator of urine concentration. It's not showing us kidney function. It's merely used in the calculation of neurotransmitter levels with no diagnostic value. Lower levels of creatinine can be an indication of more dilute urine, whereas higher levels can be attributed to a more concentrated urine. So what's important to know about sample collection for neurotransmitter testing? How do you decide between a 24-hour versus a spot collection? 24-hour is going to allow you to measure the average excretion of neurotransmitters over a day, and it's reflective of the influences of foods and stressors. It's the only viable option for patients with kidney disease. But the compliance can be difficult, and even one missed void can skew results. So that's here, the 24-hour testing. And this is the spot testing on the right, meaning the first or second morning void. It's going to allow you to measure baseline neurotransmitter levels with less influence from environmental stressors and foods throughout the day. It correlates well with 24-hour results. And it's the more convenient and popular option. Plus, it saves your patient from having to carry around the dreaded orange bucket all day. The second void was the industry standard for a long time, and so a lot of providers are still really comfortable using it, and that's fine. But recent studies have indicated that the first void is just as reliable, if not more so, in order to capture those baseline levels free of outside influences such as food and stressors. The second void can be difficult for patients due to the need to wait several hours to eat, drink, exercise, and start their day. So generally, we recommend that first morning void. Why does your patient need to avoid bananas and certain foods prior to neurotransmitter testing? Well, bananas and the other foods on these lists could increase serotonin levels. On the top list here, alcohol, nicotine, caffeine, and tyrosine-rich foods could contribute to higher catecholamines, dopamine, norepinephrine, and epinephrine. Strenuous exercise the day before testing could also contribute to higher catecholamine levels. So we recommend avoiding these foods for 48 hours before testing, as well as avoiding the substances, alcohol, caffeine, nicotine, and these foods before testing. Rigorous exercise, please avoid for 24 hours before testing too. And a way to address this with some of your patients who are having a hard time avoiding these foods is to consider keeping a diet diary for those 2 days before collection. So if the results seem skewed, you could check to see if they didn't follow the recommendations. But what if your patient can't or won't do the food avoidance, or they won't stop smoking? Is that okay? Well, the test will give you the most valuable information if the avoidance has been completed. Consuming these foods could bring ambiguity to the picture, making your test interpretation more difficult. So consider helping your patient with a 2-day meal plan, or have them use the second morning void to try to minimize the effects of foods of the day before. While 24 hours off nicotine is best for those patients who can't abstain, just make sure that the AM urine is before their first morning nicotine use, and also have them avoid waking in the middle of the night to smoke or vape. Now onto the cortisol awakening response. So the cortisol awakening response, or the CAR, is the natural rising cortisol that happens about 30 minutes after awakening, and it's followed by a noticeable drop 60 minutes after awakening. But what does it add to your results? Well, it can provide information about HPA axis reactivity and function because it reflects the anticipation of stress. It can pick up early HPA axis dysfunction that might not be revealed by the diurnal cortisol profile. So in this example, the AM60 should be less than or equal to the waking value, but instead it is showing as very high. So a result like this could give you additional treatment considerations, such as building in some self-care into the morning routine, or maybe phosphatidylserine, career change, some meditation, transitioning their teenager into adulthood, anything that could help to reduce that morning stress. So I wanted to show you here on the left, you're looking at the diurnal cortisol profile with those 4 samples, AM30, noon, evening, and night. And on the right, you're looking at the diurnal cortisol graph plus the cortisol awakening response, which in addition to that AM30 is also giving you the waking level and the AM60 level. Many providers are going to use the CAR with their very first cortisol testing in order to determine the baseline. Other situations when you might add the CAR is when someone's sleep is pretty good, but their AM30 is quite low, or if somebody reports feeling stress upon waking, but the AM30 isn't elevated. I usually run it as a follow-up to a diurnal cortisol report when the AM is low, but the levels for the rest of the day are showing up to be within range. So in these cases, I'm suspecting that maybe there is a late cortisol awakening response. So I'm going to follow up a few months after the initial diurnal cortisol to check out that CAR to see if they do have a late AM rise. And this is a list of conditions that are associated with an abnormal cortisol awakening response. Think about any condition that would involve stress upon awakening, or on the other hand, trouble waking up or getting out of bed. So things like PTSD, seasonal affective disorder, so prevalent right now, night shift work schedule, sleep apnea, short sleep cycles, older age, depression, lack of morning sunlight exposure. Any of these things would be good indications for running a CAR. And how do you interpret the CAR? In this example, you can see that the rise is low, the CAR rise, so that's the AM30, and the decline is high, AM60. It should be opposite. And you can follow that green zone here to see what should be happening. The AM should be rising, and the the 30 should be rising, and the 60 should be falling. So in this example, the rise is low and the decline is high. And I know that this language can get confusing, so let's break it down a little bit more. Ideally, 30 minutes after waking, the cortisol should be 35 to 60% higher than it was when the person first opened their eyes for the day. So this is the rise. Here you see the dotted line at the waking value, and then another dotted line above to show where the rise should be. A rise that is less than expected means that cortisol didn't rise enough, or maybe even dropped, which is what you see here. On the right, 60 minutes after waking, cortisol levels should recover back to the lower AM0. They should recover to the AM0 level. This is the decline. So think of this as a noun instead of a verb, which can help to remove some of the confusion. On the left, the patient CAR rise is less than expected, meaning it should have gone up, but it went down. And on the right, the patient's decline is greater than expected, meaning it went up when it should have gone down. What if your patient wakes in the middle of the night or at 4 a.m. and then they go back to sleep until 7 a.m.? When should they collect? Well, if you wake in the middle of the night and you're able to return to sleep, and that's a normal pattern for you, you can collect after your usual waking time. Just avoid turning on the lights as much as possible, because that could impact melatonin levels, which could then impact cortisol levels. Getting up to use the restroom is fine as long as the patient returns to sleep. But if the patient wakes up earlier than usual, or they wake up in the middle of the night and they can't return to sleep, then it's preferable to collect on a more normal day. In the next section, I'm going to share some pearls regarding diurnal cortisol testing and treatment consideration. So what is the significance of adrenal phasing? Well, it's a way to categorize the degree of HPA axis dysfunction, and it can help you with your treatment approach. So because the morning cortisol level is reflective of overall HPA responsiveness and adaptation, we base phasing on that AM30. So an upper range or high cortisol at any point is considered phase 1. It can also indicate an optimal AM cortisol and lower values throughout the day. A more long-standing HPA axis dysfunction involving a suboptimal AM cortisol is going to be reflected in a phase 2 pattern, and phase 3 is a low AM value and sometimes even a flat line throughout the day. So this chart's going to spell out what I was just explaining, and you can find this on the website. And here's how you can tailor your treatment based on your patient's HPA axis phase. And you can see that their lifestyle modification is suggested for phase 2 and phase 3. Things such as deep breathing, stress management, exercise, optimal diet have all been shown to really help to impact HPA axis balance. And as well, you'll see that vitamins B5, B6, vitamin C, and adaptogenic herbs, and even adrenal glandulars are also a consideration for phase 2 and 3. Hydrocortisone is reserved for phase 3 cases only. Speaking of hydrocortisone, how long does one stay on it? Well, it has a very short half-life, about 1.5 hours, so it's unlikely to suppress the HPA axis at low dosages. But depending on the severity of HPA axis dysfunction, you can dose up to 20 milligrams per day, because that's about what the adrenal gland is going to produce in a day. And that usually looks like 10 in the morning and 10 at noon, or 10 milligrams in the morning, 5 at noon, and 5 in the afternoon. Many providers will start with a 2.5 milligram dose in the morning and work up as needed. That is what I do with my patients, because I found that it can be very stimulating for some people. And you're also going to want to give the hydrocortisone after that morning rise of cortisol, so as not to interfere with it. The first round of hydrocortisone supplementation is going to take about 3 months, and then the patient's going to stop to 4 to 5 days so that they can retest, see if their endogenous production and or their symptom picture has improved. However, if severe symptoms and the phase 3 persist, then you may want to continue supplementation for another 3-month increment with retesting. It's important to avoid exceeding 20 milligrams per day so as not to suppress cortisol production. And long-term use has been shown to be likely safe in patients who have an ongoing need for support, but just continue to support with HPA axis adaptogens, nutrients, stress management techniques, etc., to make sure that they are all in place for supporting the adrenal gland. So now let's talk about reproductive hormones. Why is the supplementation range higher than the reference range? Well, our supplementation ranges are based on the work of Dr. John Lee. They reflect levels of a healthy, youthful endocrine gland, and it's within these ranges when one usually feels their best. Dr. Lee began this process by treating patients with progesterone cream at physiologic dosage ranges and then looking at their symptoms. When he was tracking their symptoms within the ranges, he was able to tell when symptoms and bone density improved, and then he used those levels to establish his supplementation ranges. His original data has been validated by our doctor's data database of over 180,000 processed salivary test kits over time. Metabolic syndrome is going to affect androgens very differently in men and women. In men, insulin resistance or insulin spikes are going to be associated with a decrease in sex hormone binding globulin, which is going to lead to low testosterone, decreased LH, and an increase in estradiol. Whereas in women, metabolic syndrome or insulin resistance is going to decrease sex hormone binding globulin. It's going to lead to an elevation of androgens and a disordered release of FSH and LH. And here's another graphic showing you how metabolic syndrome affects androgens in men, starting with adipose tissue. We're going to follow these orange arrows to the left. Adipose tissue contributes to insulin resistance, which is going to lead to decreased LH and decreased testosterone. And now we're going to go right with the blue arrows here. Adipose tissue is going to lead to increased estrogen levels via aromatization, going to increase sex hormone binding globulin, and also lead to lower testosterone levels. And this is showing you how it's going to affect women, how metabolic syndrome is going to affect androgens in women. You see here insulin resistance, leading to hyperinsulinemia, which leads to a decrease in LH and sex hormone binding globulin, which is going to contribute to increased androgen and the symptoms that go along with that. There's a lot more to look at here, so I encourage you to take a look. It's a really great graphic that really shows you how metabolic syndrome is going to impact hormones in women. And that's also available on the website. If you're planning to prescribe hormones, it's really important to understand the difference between progesterone and progestins. Here you see progesterone on the left, which is a common, and you see a common progestin on the right. Bioidentical progesterone shares the same molecular structure with what's produced endogenously in the human body, whereas progestins have a slightly different molecular structure, which is going to lead to different effects in the body. Progestogens is an umbrella term, which means hormones that affect progesterone receptors. Both progesterone and progestins affect progesterone receptors, but they have different effects. So to highlight these differences, on the left, in the yellow, you're looking at bioidentical progesterone and how it can be safely supplemented during pregnancy to prevent miscarriage, whereas progestins, here in the blue on the right, are used to prevent pregnancy. And certain progestins could cause birth defects if they're used during pregnancy. On the left, again, on yellow, bioidentical progesterone is available over the counter through a compounding pharmacy or as a pharmaceutical product like Prometrium. And progestins are what is in HRT and birth control. Research has shown that natural progesterone is protective and preventive of breast cancer, and it may also be helpful in preventing cardiovascular disease and stroke, whereas progestins can contribute to breast cancer, coronary heart disease, strokes, and pulmonary embolism and dementia. So how to dose bioidentical progesterone? Well, we base it on body weight. So you'll see here that if someone is under 150 pounds, we're shooting for a 20 to 30 milligram per day dose. And if someone is over 150 pounds, we're looking, and this is in women, by the way, not in men. If a woman's over 150 pounds, we're looking at a 40 to 60 milligram per day dose. I recommend starting low and working up to those doses. If the patient is premenopausal and hopes to conceive, only dose during the second half of the cycle, so days 7 to 28 in a 28-day cycle, which is probably going to actually look more like 14 days to 28 days in a woman who wants to conceive. If the patient has a clear idea of when they ovulate, then they can wait to start the progesterone after ovulation so as not to interfere with it. If there's absolutely no interest in conception, then it's days 7 to 28 when they're going to be using their progesterone. And I misspoke initially, and I'm just going to repeat that. If the patient has conception goals, then they're going to be starting their progesterone after they ovulate, or more closely to day 14 to 28, as opposed to day 7 when there are no conception goals. So what about dosing progesterone for men? Well, progesterone is not just for women. So it is a consideration for men because they produce it and it impacts brain, bone, prostate, and sperm health. You might consider progesterone supplementation in men who have prostate symptoms, such as a decreased urinary flow or to treat BPH. It can inhibit the proliferative effects of estrogen on the prostate. It's often combined with testosterone therapy because it can inhibit 5-alpha reductase to help prevent conversion to DHT. It's also often dosed with chrysin, which is a bioflavonoid and a natural aromatase inhibitor. So often you'll see progesterone and chrysin together. A typical dose for a man is about 5 to 15 milligrams per day. When somebody is on oral contraceptives and they want to do hormone testing, it's going to show how the pill is affecting hormone balance, which tends to be very predictable with the pill because it's going to suppress ovulation. And that's going to lead to lower levels of progesterone and is also going to contribute to lower range estradiol and even suboptimal testosterone levels. Because progesterones can't be measured by the progestins, because the synthetic progestins can't be measured by the test system, the results are going to reflect suppressed production of progesterone because only progesterone can be measured by the test system. IUDs that are progestin-based, such as the Mirena, is a slightly different mechanism. It thickens cervical mucus and it inhibits sperm movement and viability. So you may see normal or low range estradiol and progesterone with a hormonal IUD, and that is why many providers do choose to test. Can you supplement progesterone for women on oral birth control pills who have progesterone insufficiency? There is competition between the progestin in the birth control pill and topical progesterone at the receptor level, and it could negate the effects of the breast, brain, and cardiovascular protection of the progesterone supplementation. It's simply unknown how progesterone supplementation is going to influence the effectiveness of hormonal contraception. We simply do not have that research. So what's the difference between the three estrogens, and when should you consider ordering all three? Well, estradiol is the strongest of the three estrogens. It's important for reproduction, proliferation. Estrone is the predominant estrogen after menopause, and it's been shown to have more, it's been shown to be associated with breast and endometrial cancer risk. Estriol is the weakest and the most protective estrogen. It's going to weakly bind to estrogen receptors, and so it can serve in a protective role. And when should you consider ordering all three of the estrogens? Well, testing all three of them is going to enable you to calculate the estrogen quotient, which is going to give you an indication of risk related to the ratio of estriol over estradiol and estrone. It's relevant for women over the age of 45 or anyone with a personal or family history of breast, uterine, or ovarian cancer. It's great for prevention-focused practices, and typically it's not ordered for men because we just don't have a reference range for men for the estrogen quotient. What's the difference between the EQ and the PGE2 ratio? Well, both are ratios that can help you approximate the risk of proliferative issues and target your supplementation to minimize that risk. While the EQ has a reference range for women, the PGE2 is relevant in both women and men. Sufficient quantities of estriol, as indicated by an EQ of greater than 1, optimal being greater than 1.5, can help to antagonize the proliferative effects of estrone and estradiol. A low EQ does not necessarily associate with any symptom pattern. The PGE2 ratio is going to give you a target to help to minimize prostate risk in men and to help protect breast, heart, and bones in women, as well as to help to counterbalance the proliferative effect of estrogen. Achieving an in-range PGE2 ratio can help minimize symptoms and can also help you to determine proper supplementation, both from an estradiol and a progesterone standpoint. So we talked about that. I'm just going to skip over this one because we talked about this one in the previous slide. So let's talk about melatonin, which can also be measured in saliva. What if your patient has trouble falling asleep, but their melatonin is high at night? The most common reason for this pattern is recent supplementation with melatonin or 5-HTP, because 5-HTP is on the serotonin pathway. Serotonin converts into melatonin. Taking SSRIs or SNRIs can also play a role. Also, lack of light exposure during the day could lead to higher melatonin levels at night, as well as phytomelatonin from the diet could play a role. And there's some foods that are listed here that have particularly high phytomelatonin levels. And lastly, consider that insomnia in this patient may not be due to low melatonin levels. As I mentioned, how do you address melatonin levels? More exposure to sunlight and time outside during the day is going to help with that. Inside, you can use a full spectrum light box. Inquire about your patient's supplementation and consider neurotransmitter testing to rule out elevated serotonin in these patients. The question of safety of melatonin for children comes down to two main things: side effects, and then also whether or not melatonin supplementation could affect the timing of puberty. The research on melatonin in the general population of children is pretty lacking, but we do have a few studies involving neurodivergent children on the autism or ADHD spectrum. The concern that melatonin might affect the timing of puberty comes from the fact that melatonin levels decrease just at or before children begin the Tanner stages of puberty. So it's thought that the drop may play a role in onset. The concern is that supplementing could interfere with pubertal timing. So I wanted to show you right here, this is where that decline takes place just before puberty is going to set in. These are the studies in efficacy involving the neurodivergent children. The ages ranged from 2 to 17, and they were given doses between 2 and 10 milligrams, which are pretty hardy doses. Only mild, it's been found to be quite well tolerated in children, and only mild adverse events have been noted, and those adverse events may be related to those very high levels. We usually recommend 0.5 to 1 milligram in adults, keeping in mind that the pineal gland is only going to be producing about 0.3 to 0.5 milligrams per day. But generally speaking, it's been very well tolerated in children, and it has a beneficial effect on sleep. Only 3 studies have specifically tracked the onset of puberty in relation to melatonin use, and in each study, it was a secondary outcome measure. All of these studies showed normal pubertal timing, although one had the place to indicate your perceived timing of puberty, and one of those tests perceived a later timing of puberty with melatonin usage. This is a brand new 2023 paper. It's a small study of 50 boys aged 14 to 18, and they found that higher serum melatonin levels were found in boys with constitutional delay of puberty compared to other age-matched boys, and that those higher levels of melatonin were inversely correlated with testosterone and FSH. Researchers hypothesized that supplementation of melatonin could interfere with the triggering of those important pubertal steps. So what I do with patients is right around puberty, I do not have them using melatonin. I have them using other things such as L-theanine or valerian or something else that's going to help them, magnesium, help them with falling asleep at night until they're well into puberty, and I'm not concerned about supplementing with melatonin interfering. So just a few more questions related to saliva collection practices. How long to wait after last hormone dose before collecting saliva? So patients on hormones need to follow these proper dosage intervals, just like we talked about with the HuMap, but they're slightly different for saliva. Topical hormones, the last use should be between 12 to 24 hours before start collecting that first saliva sample. For sublingual hormones or troches, there needs to be a window of 24 to 36 hours before collection. Very important to follow the use with 2 full glasses of water to cleanse those tissues in the mouth. If someone has particularly dry mouth, it's really important to do this because we will often find residual, and that's when they're testing, and that's going to impact the results. For oral hormones, such as pills, they can continue their use as prescribed on the day of collection, which is opposite of the HuMap. And for injections and subcutaneous pellets and transdermal patches, they're going to collect at the halfway point between their doses. So for example, if someone's using a patch and they put a new patch on Monday, then they could collect their samples on Tuesday, assuming that it's a twice-a-week patch. So to figure out if your patient properly timed their hormone dosing prior to collecting their sample, you can look at this questionnaire that they filled out when they submitted their samples. So this can be really helpful to take a look at this. You're looking at what form of hormone they're using, and this is giving you an indication down here of when they actually used it prior to testing. So this can solve a lot of mysteries when you see excessively high levels in patients on results because maybe their dose interval was too short, or if you're seeing very low levels on someone who's supplementing, you're expecting them to be higher. Perhaps there was a very long dosage interval. So with irregular cycles, and this is the last question, and then I'm going to open it up to questions. With irregular cycles, when should my patient test both salivary or urinary hormones? Well, it's the same for both. So if someone has a typical 28-day cycle, they're going to collect right around day 21, give or take 2 days on either end. So we say they can collect on day 19, 20, 21, 22, or 23. Somebody has a longer cycle, so more than 28 days, they're going to be testing closer to, you're going to count back 7 to 9 days from the end of their usual cycle to determine when they're going to collect their samples. If someone is very clear about ovulation pains, or they know when they ovulate, then they're going to collect 7 days after ovulation. All of this is to try to catch that luteal surge of progesterone. For a short cycle, less than 14 days, you're going to collect somewhere between the 7 to 9 day period. And if somebody has a very unpredictable or infrequent cycle, you're going to be collecting after day 14 and before day 1. But if there's a lot of chaos in someone's cycle and you don't know if it's going to be short or long, and if it's they tend toward some months a very short cycle and some months a very long cycle, it's a good idea to follow this unpredictable, infrequent recommendation, and then put the samples in the freezer for 2 nights. If after the second night they did not bleed, they can rinse out the tube and air dry it, and reuse it to catch the next luteal phase. So that is the end of my presentation, and I am happy to take some questions now.